Chronic rhinosinusitis, CRS, presents differently in pediatric and adult patients due to variations in commensal microflora, immunity, and anatomical responses. Starting with the microflora differences. In young children, Streptococcus pneumoniae is found in 50% of cases, compared to 26% in adults. Haemophilus influenza and Moraxella catarrhalis are prevalent in 40% and 24% of pediatric cases, but they are rarely seen in adults. Conversely, adults have a higher prevalence of Coagulase-negative staphylococci at 35%, compared to 30% in children. Staphylococcus aureus is more common in children at 20%, while it drops to 8% in adults. Immune differences play a crucial role. Children have an immature immune response, with a defective response to polysaccharide antigens such as IgG2 and IgA. Adults generally have a mature immune response, although a subset may present immune deficiencies. When it comes to clinical history, pediatric CRS is often self-limited, showing improvement after the age of 6 to 8 years. Adults, however, typically do not experience spontaneous improvements, making their condition more chronic. The histological differences are also noteworthy. In children, CRS is mainly neutrophilic, with less basement membrane thickening, but there's more mucus gland hyperplasia and increased mast cells. In adults, the condition is predominantly eosinophilic, reflecting a different underlying inflammatory process. Endoscopic findings differ as well. Polyps are rare in children except in cases of cystic fibrosis, while adults frequently present with polyps. Finally, CT scans reveal that in children, CRS tends to show more diffuse sinusitis, affecting multiple sinuses. In adults, the sphenoid and posterior sinuses are less often involved, focusing more on isolated areas. Understanding these differences is key